Okay, thanks, Michelle. Good afternoon, everybody, and thank you all so much for joining us on our fifth CJE Academy presentation and our second one that we've done virtually. We never thought we'd be doing it this way, but we pivot and we change as we need to. So why are we doing CJE Academy? For those of you who might not be as familiar with our agency, we are a nonprofit agency, and our mission is focused on enhancing the lives of older adults and their families and caregivers through a really broad network of services, including life enrichment programming, housing, healthcare, and community services, like our home delivered meals program and transportation services. We're coming up on our 50th anniversary. We've been around since 1972, and historically, we're probably most well known for our services to older individuals who need help when life gets tough, when they're having an illness or their financial resources run out or some other challenge that they're facing. But what you might not know is that we also offer a number of other programs when there isn't a crisis. They range in things from health and wellness screenings to help with selecting the best Medicare supplement plan. And for years, we've offered a number of adult educational programs, things like how to downsize or how to plan for a successful retirement. On the professional side, we offer many presentations to social workers and nurses so they can get their required continuing education credits. We actually just finished up our annual professional series called Transition to Wellness, with topics ranging from senior bullying to mindfulness that was very well attended. But we feel like we can do more and have more innovative presentations for people like yourselves and professionals, leveraging our expertise in the field of aging and what we've learned from research about how to age in a positive way. Many of us have heard these astounding statistics that between now and the year 2030, the number of adults age 65 and older in this country will double from almost 37 million to more than 70 million. And we are very aware that CJE needs to offer more educational opportunities that address critical issues that are going to impact adult children who can be as young as 45. For example, we have a support group for adult children with parents, perhaps only in their 60s, who have early onset dementia. You know, we often say that CJE is one of the best kept secrets in our community. So we started CJE Academy as a way to share our expertise on aging and related issues with the broader community. And we have a knowledge base to help educate and inform our community on ways and options to remain healthier and more connected emotionally, intellectually, and psychologically as we or our loved ones age. You know, I'm often asked what's going on with CJE with respect to the pandemic. How has it impacted our agency and how are we responding? There isn't an aspect of what we do at CJE that hasn't been impacted by the COVID, whether that is in our nursing home, the Lieberman Center, or our assisted living and memory care community, Gidwitz Place and the Friend Center in Deerfield, or our brand new building, Tamarisk North Shore, which is a new independent living. But also all of our home and community-based services have been impacted and had to change what they do. I'm pleased to say that while we weren't successful in keeping COVID out of our residential settings altogether, the impact has been relatively minimal compared to some of the headlines that you read, and our staff have really worked exceptionally hard to manage the risk, keep the residents safe, keep their family members safe, and keep each other safe. So we are almost 7 months into dealing with this thing. We don't really see a light at the end of the tunnel per se, although we've gone several months now without any new cases amongst our residents, either in Deerfield or at the Lieberman Center. So we're pleased to be able to keep it pretty well under control and to begin inviting family members back into the building to have visits with their loved ones. So welcome to this presentation tonight, and I hope it exposes you to a whole new view of what CJE can do for you now or in the future. And we also welcome your ideas on future topics that might be of interest to you and your friends. So I'm going to turn things back over to Michelle, who will introduce you to our speaker. Michelle?
Great, thank you, Dan. And now I want to introduce Dr. Jennifer Mundt. She is a sleep psychologist at Northwestern University Feinberg School of Medicine. She is an expert in the field of behavioral sleep medicine and treats her patients at the Center for Circadian and Sleep Medicine. So welcome, Jennifer, and I'm going to turn it over to you.
Okay, thank you. I'm just going to move this video off my screen so I can see the PowerPoint. Okay, Michelle, and just let me know at any time if you can't hear me, if there's a problem. So I'm happy to be here with you all tonight. I wish we were all in person. We had originally planned to do this in May, I believe. And then of course this got transitioned to being by Zoom at a later date, but I'm glad that it's able to still work out. So I'm going to be talking about CBD and CBT, so cannabinoids or cannabidiol and cognitive behavioral therapy. And we'll talk about each of those, what they are, and the evidence that there is to support using those for sleep, in particular insomnia. I'm going to start with just a little bit of background about me, just to kind of know sort of what I do and how I got to do this. So like Michelle just said, I'm a sleep psychologist at the Center for Circadian and Sleep Medicine. So this is our Arcus Pavilion, our downtown clinic where we normally see patients. But since March, we have been doing virtually all telehealth, which is actually going really well, and I'm busier than ever. So we're still seeing a lot of patients these days, but doing it all by telehealth. So I'm, excuse me, assistant professor in the Department of Neurology. I train our medical fellows, psychology students, teaching them about behavioral sleep medicine and treatment for insomnia. So before that, I got my PhD in clinical psychology at the University of Florida down in Gainesville. So that's where I was for 4 years, training, researching sleep and pain in particular. And my clinical emphasis was in health psychology. So researching and learning clinical treatment of that interaction of psychology and chronic medical illness or different medical issues. After that, I did a clinical internship at the Ann Arbor VA, and then I did a year-long fellowship at the Durham VA, where I specialized in behavioral sleep medicine and primary care. So after that, I came to Chicago, so I've been here for 2 years now working at Northwestern. And this term behavioral sleep medicine might be new to you. It's honestly a pretty niche field, and so a lot of people have not heard of it. There's this broader field of behavioral medicine, which is synonymous with health psychology. So that would include psychologists who work in like a cardiology clinic or a GI clinic or a cancer center. So behavioral sleep medicine is a specialty within that. And so that's what I do full time. So essentially what that is any kind of behavioral or non-pharmacological treatment for sleep issues. Primarily what I treat is insomnia, and that's what we're going to be focusing on today. But I also do treatment for things like nightmares, help folks who are having problems with their CPAP, like anxiety or claustrophobia. So I do a variety of different treatments in our clinic. So we'll get into the topics for tonight, and first starting with just a little overview of what each of these are before I get into more depth. So CBD is cannabidiol, which I'm sure probably almost everybody has heard of at this point. It's become really widespread, really popular. So as you probably already know, this is, along with THC, it's one of the major psychoactive ingredients from cannabis. So THC is that ingredient that's responsible for that high that we think of when we think of cannabis. CBD does not cause a high, but it is thought to possibly help with a wide variety of health conditions. We're going to talk specifically about sleep and what the evidence is for that. So this is widely available over the counter as a supplement. CBT, or more specifically CBT-I, is cognitive behavioral therapy for insomnia. So this is the treatment that is the gold standard or first line treatment for insomnia. It's a brief therapy, usually somewhere around 4 to 8 sessions, although it can be even shorter than that at times. So it's a therapy where we're looking at thought patterns and behavior patterns, looking at what are the things really underlying the insomnia problem and addressing those in order to long-term treat the insomnia. And this is a treatment that's provided by folks like myself who are licensed health professionals, including nurses and social workers and even some physicians. But there's also resources where you can go through this treatment on your own. There's books and there's digital resources. And I have some information at the end about some of those resources if you're interested in looking into that. Okay, so there's just our brief overview of these two concepts. So we're going to start with talking about cannabinoids. The title of this the talk is CBD, but I am going to be talking a bit about more broadly cannabinoids, including THC. The first point that I want to raise is something that you may have noticed if you've seen all of these different products that include CBD, is it's pretty easy to get this impression that CBD is some sort of panacea, because there's so many different types of products. I've listed here just some that I could find. There's probably even more than this, but all sorts of, from edibles to topicals, food, beverage, even products for pets. There's a lot of different products and formulations containing CBD, and the benefits that are claimed are really wide and far reaching. And so again, this is not an exhaustive list, but I think this was from just a couple of company websites looking at the products they had for all of these different reasons. And I'm sure there's many other products that are supposedly targeting other things. So what strikes me is that this is a really broad range of things, and it seems unlikely that CBD is actually going to be that helpful for all of these things. This is such a wide variety of different conditions and problems. What I found interesting is I actually came across a few companies, I included their logos here, a few companies where they actually include this term panacea in their company name, which to me is interesting, because to me the term panacea is something that doesn't exist, right? It's kind of like snake oil. So it's interesting that this concept is actually being embraced by some companies. And I think a lot of people are viewing CBD as like this miracle that will just help with everything and help with general wellness. So again, I'm not going to be talking about the claims for all these other medical issues, but I will be talking about the science for sleep. And when we dig down and look into these products for sleep, the first thing that I find is really interesting is that there's these conflicting claims about what CBD can do. So on the one hand, there's lots of these products that are marketed to help with sleep. So this is from one particular company called Medterra, and side by side on their website, they've got these two products. They both contain 25 milligrams of CBD. One of them is supposed to help you sleep, and one of them is supposed to help you stay alert. And those are about as close to opposites as you can get, right? So right off the bat, I'm a little skeptical of, okay, well, if these products are actually doing that, if they're helping you sleep or stay alert, then is it even the CBD that's doing it? In these products, you probably can't see, it's very small, but they list some other herbs that they contain. So thinking like a scientist, my thought is, well, if they both contain the same amount of CBD, but they do different things, then it must be those other ingredients that are the active ingredient, if these do help at all. So I think it's good to be sort of critical and skeptical when looking at these products and evaluate how likely is this really true. And I think that's important because you can see the price tag on these. They're not cheap. So they, maybe they're harmless, maybe they don't have any negative side effects, possibly. But even if that's true, they can be quite expensive. So is it really something you want to spend more than $1 a pill or $1 a gummy on? So I'm going to be reviewing what we know so far about the science of different cannabinoids in sleep. And these are just pictures of a few review papers that were all published within the last few years, including this one on the bottom was just published this year. So I got a lot of information from that one. So these are papers where they looked at all the different studies that have been done on different cannabinoids, so including THC and just cannabis as a whole and CBD, and looked at what studies have been done both in animals and in humans. And to give you just a summary up front to kind of get to the point, these are some phrases that I pulled from those articles. And the gist is that the research is kind of early, and you can see the tone of these, it's pretty hesitant. So scientists aren't going to make big claims that this helps or cures anything. They're going to speak from the data. So you can see these statements are pretty guarded and hesitant, saying, well, maybe this helps. It has the potential to have a benefit. It may help sleep. The research is mixed. So this is the tone of these review articles, that they're not stating, oh, this definitely helps sleep, everyone should be taking it. They're saying this is something that looks interesting, it might help, but we need more research. So that's really the take home here, but I'll get into a few more details behind that. So here's a summary of the evidence so far of what type of cannabinoids might be helpful for sleep and for specific conditions. So there is weak evidence that synthetic THC could help obstructive sleep apnea and trauma-related nightmares. So there have been some preliminary studies done with a couple of these synthetic THC compounds showing some benefit. However, there is not any evidence to support the use of any cannabinoid for other sleep disorders, including insomnia, restless leg syndrome, REM behavior disorder, and narcolepsy. And what's really important, what I put here in this blue box, is that there are no randomized controlled trials in this area. This is what we really need to be able to say that a cannabinoid is effective, that it's not just a placebo effect. We need a placebo-controlled randomized trial. And so that's lacking so far. So it's not to say that we know it doesn't work for these disorders, but we just don't know yet that it does. The evidence is not there. I wanted to include this quote from this most recent review article because I think it's a really nice summary of where the research is at. So I'm actually just going to read this quote to you, even though it's a little bit long. But these authors from this article this year said that at present there is limited evidence to support the clinical use of cannabinoid therapies for the treatment of any sleep disorder. And that's because of the dearth of published research and moderate to high risk of bias in the studies that have been published. But they do say that there's these promising signs and that it should be studied further. So I think that's a nice summary of where things are now, that there's kind of some hope and some promising evidence, but not strong enough yet to make any big claims about using CBD, THC, or cannabis for sleep. Some areas that we definitely need to know more about. The research in the future needs to look at actually people who have diagnosed sleep disorders. So one thing that was noted in these reviews is that a lot of these studies in humans, they've mostly been done with people who are healthy. That is, people who don't have a diagnosed sleep disorder. So we really need that to be included, people who have a clinician diagnosed insomnia or whatever the disorder is. And then we need to know more about what's the best formulation and what's the best route of administration. So a formulation meaning just CBD or combination of CBD, THC, and in what proportions, because there's some products that are high THC, low CBD, some products are high CBD, low THC. So there's a lot of these different formulations. And then there's a lot of those different routes of administration, the pills, the oils, the topicals, the bath salts, all these different things. So those are all different ways of getting this into your system. And then we also don't know about the best dose and the best timing of the dose. Timing is likely to matter quite a bit. I'm sure that's probably true in a lot of areas of medicine, but it's definitely true with sleep. The timing of any medication or substance makes a big difference in what effect that's going to have on sleep. And we also need to know more about drug interactions. So I think right now a lot of people are just assuming CBD is harmless, benign, no side effects, but I think we need more long-term research to know whether this does interact with other substances. And along with that, we need to know more about both the short and the long-term safety, including like the next day. Do people feel any sleepiness the next day, any cognitive impairment? Are they safe to drive? Those kind of things are really important. We need to know more about dependence and withdrawal, whether that's something that could happen with these different formulations. And for sleep specifically, we need to know more about changes in sleep architecture that can happen. So we're going to take just a little detour to talk about what sleep architecture is and why that might be important. So this is a picture of sleep architecture. What sleep architecture is, it's just basically the pattern of going through these different sleep stages over the course of the night. And so you can see in this diagram that it almost looks like a city skyline, right? It looks like you've got these buildings and this skyline. So I'm assuming that's why it's called sleep architecture. And so this is a typical pattern. This is an example of someone who's a healthy young adult. And so sleep architecture does change with age, but this is a typical pattern in someone who's a young, healthy person. So what you can see here, hopefully you can see my mouse here, but this on the left here are the different stages. So there's awake, and then there's stages N1, N2, and N3. So those are all non-REM sleep. So non-REM 1, non-REM 2, and non-REM 3. Stage 1 is what we would consider light sleep, and then stage 3 is deep sleep. So you start out the night going through light sleep, and then this medium, and then deep sleep. And then eventually you're going to come into REM sleep, that rapid eye movement sleep where you're doing most of your dreaming. So this is one cycle here, going through these non-REM stages and then REM sleep. And in adults, one cycle of sleep lasts about an hour and a half to 2 hours. That's the average amount of time. So you're cycling through these stages every hour and a half to 2 hours throughout the night. And it's really typical, or it's completely normal that you will wake up during the night. So waking up is a normal part of sleep. I think a lot of people, at least folks I talk to in clinic, have this wish or this conception that sleep should just be unbroken and without waking up during the night. But waking up is completely normal, and that's going to happen periodically. So you can see in this example, this person is popping up into wakefulness a handful of times throughout the night. And you may or may not remember that. If it's really short, you just don't remember being awake, but it does happen to everybody. So when we talk about sleep architecture and how that might change with cannabinoids, we do know from some research on THC in the past that THC does tend to suppress REM. And this happens with sleep medications as well, that they can suppress REM, or they could suppress slow wave sleep or that deep sleep, meaning you don't get as much of that stage. So that could potentially mean you're not quite getting the sleep the way that your body naturally would get it. With THC, there's also some evidence that it does initially help to decrease the amount of time it takes to fall asleep, but that might be something that you develop tolerance to. So it might not be something that will work long-term if you smoke marijuana every night. It might be that effect lasts for a couple of weeks and then you develop tolerance to it. And then there can also be sort of a withdrawal effect. If you stop using THC, then often sleep is worse for a while and eventually gets back to normal. So these are things that we need to know more about for different formulations and for CBD, since that's a newer thing that people are now using. And this is, along with our detour here, this is not necessarily related to the topic of CBD, but I thought this would just be some useful information just to talk a little bit about age-related changes in sleep. So this relates to that sleep architecture we were talking about. This picture here is showing, there's some different acronyms here that I'll explain, but this is showing basically the amount of time that we spend in these different stages and how that changes. So starting with age 5 and then through age 85. And what you can see is that this total amount of sleep, of course, decreases through childhood, and then it levels off in adulthood. And there's some changes that happen in older age, so sort of past the age of like 55, 65, there's some changes here, which I've listed on the right. So this part in dark blue here with this label WASO, W-A-S-O, stands for wake after sleep onset. So that amount of time that people are awake during the night and the number of awakenings increases with older age. And there's also a decrease in deep sleep, which is this green part in the middle. SWS stands for slow wave sleep. So you can see that narrowing with increasing age. And then conversely, the amount of light sleep, this stage 1, which is the light blue at the bottom, you can see that slowly increasing toward with increasing age. So those are some changes that happen. There's also this shift to an earlier circadian phase, which just means that as people get older, they're more likely to be morning people. I'm sure you've probably all heard about that or maybe experienced it yourself, that a lot of older folks will start to shift to where they go to bed earlier, they wake up earlier. So there's a shift in that, the timing of sleep, your circadian rhythm. Okay, so before we get into CBT-I, just to summarize what, where we're at and where the research really needs to go, I think with more research, and there's a lot of research being done now because this is so popular, I think we'll eventually learn what specific conditions certain formulations are useful for, but we really need to narrow down that who, what, when, why, how, those questions of, okay, what specific sleep disorders benefit from specific formulations with a specific route of administration, specific dose, specific timing. So all of those details need to be researched to figure out what actually is helpful for certain sleep issues. And like I said before, we need randomized controlled trials where we're comparing some cannabinoid to a placebo to see how much of the effect is from placebo effect and how much of it is a real treatment effect. And beyond that, I think we also will then need to compare these cannabinoids to standard treatments. So for example, if we find that CBD helps insomnia, we'd want to compare it to treatments that we have right now, like other medications or CBT-I, to see how does it stack up to things we already have. Is it as good as those? Is it better than those? That's an important thing to research as well. And a couple of other things noted in some of these review articles is that the studies in the future need to have more people in them. A lot of them have been very small, and they've been pretty short term. So we need to have longer follow-up to know more about really the long-term effects of these substances. So we'll transition now to talking about CBT-I, cognitive behavioral therapy for insomnia. Okay, so just a definition of insomnia. Let's start with that, which I'm sure you're all aware of, but insomnia is just simply difficulty falling asleep or staying asleep. And that can also include waking up too earlier than your alarm and just not able to go back to sleep. That could be insomnia as well. And so difficulty sleeping occasionally is really normal. And so everybody has at least an occasional night of poor sleep. I think most people throughout their life have some period of insomnia. Might be short term, but almost everybody goes through this at some point. And so insomnia is the most common sleep disorder or sleep problem. At any given time, at least prior to COVID, I think the numbers are higher now, but prior to COVID, the sort of baseline level of insomnia complaints was about 30% of the population. And about 10% of the population has daytime functional impairment, which means they would really qualify for a diagnosis of insomnia. But these insomnia symptoms are very common, and especially now with lockdown and COVID, insomnia has become an even bigger problem. So what causes insomnia? Really, insomnia can be caused by just about anything. So insomnia, the way I think about it is that it's a normal reaction to change or stress. So just about anything could cause it. I'm going to talk about how chronic insomnia develops. So chronic insomnia, the definition of that is insomnia that lasts at least 3 months and the person has difficulty sleeping at least 3 times a week. So that's how we define chronic insomnia. So even people who've had insomnia less time than that certainly might need treatment for it, but that's the definition of chronic insomnia as opposed to acute insomnia. So I'm going to talk about how this develops, and this is really the basis for why CBT-I works really well. Let's talk about how chronic insomnia happens. So this is showing over time from baseline to acute, short-term, and chronic insomnia. And then when you get above this dotted line here, you've crossed that insomnia threshold, you have insomnia. So this first factor that leads to insomnia, you start out with predisposing factors. So you can see this is the same across time. This is just a constant factor. Think of this as just your baseline risk of developing insomnia. And this would come from things like your genetics, your traits, your biology, personality, things like that, just things that you start with. So you may start out with a higher risk or a lower risk. So for example, let's say you've got a family history where a lot of people in your family have had insomnia. Well, maybe there's something then genetic or biological going on where maybe you have an increased baseline risk. Okay, then we add to that a precipitating factor. And so this is that thing that pushes you over that threshold to start with. So for example, this could be the start of COVID and lockdown, maybe something like that, or just any other stress in life. It could also be a good change. It could be like having a baby or getting a new job, something that's even good, but it's disruptive. It might be stressful in a way, and so can disrupt sleep. So this acute insomnia is this normal reaction when something like that happens. And then what happens over time? So let's say if magically now COVID was not an issue and we could all go back to normal, well, the stress from COVID then is gonna fade away. And so if that was the reason for the insomnia, then the insomnia would go away if this thing fades. So often these changes or stresses in life, we adapt to them or they're no longer such a problem. So the sleep will go back to normal for most people, most of the time. But it doesn't always, and that's because of this third factor. So we call these perpetuating factors. So when someone's had insomnia for a little while, what happens is that things start to change with the way they're thinking about sleep, with the habits that they have. And so those things, the way that people react to the sleep problem can actually make it worse. They can perpetuate it. And so essentially the insomnia will become this self-perpetuating thing, or the insomnia itself becomes the problem. So just an easy example would be caffeine. So let's say if you've been having trouble sleeping at night, then you compensate the next day with caffeine to be alert and get through the day, and that helps you get through the day. But if you drink too much caffeine, then that night you're going to have trouble sleeping. So you get into this cycle where it just starts to feed on itself. So that's one example, but it could be a lot of different things. And often it's really the things that people don't realize that they're doing that are making it worse. Caffeine's a pretty easy example. Most of the people that I see with chronic insomnia, they've reduced the caffeine or eliminated it because they're well aware of that. But it tends to be other things like the way you're thinking about sleep, just the fact that you become really focused on it and now you're thinking about it all the time. There starts to be anxiety about insomnia. So those are the things that tend to become these perpetuating factors that in the long term become the biggest thing that's really keeping the insomnia going. So what this means is that the insomnia can outlive that initial stressor. So if this initial stressor might have faded away, but what takes its place are maybe some of these other habits and thought patterns that just keep the insomnia going, even though that stress is gone. So that's what chronic insomnia looks like. And CBT-I is really effective because it's really targeted at these perpetuating factors, those thought patterns, behavior patterns, habits that are sustaining the insomnia. That's what we're working on. And so the things I'm going to talk about after this point, we're going to talk more about some practical things, some strategies from CBT-I that could be useful to you. And so I think they could be useful whether you're at any stage in this process. You might be someone who doesn't have sleep problems, but maybe you can learn just some things that will help maintain good sleep. Or if you ever do have sleep problems in the future, you could use them. Whether you're someone who maybe has recently developed some sleep problems, a lot of people have been. These are things that could help you to get your sleep back on track, get it back to the way it was, or at least prevent a chronic insomnia from developing. And definitely if you're at this chronic insomnia stage, these things will be very relevant to you. So I'm going to give you sort of a brief overview of some key CBT-I strategies. So just really briefly, I mentioned earlier that CBT-I is the gold standard treatment. And so this is recommended in the treatment guidelines from the American Academy of Sleep Medicine and recently from the American College of Physicians. Both of those groups have said that CBT-I should be the first choice for treating chronic insomnia. And the big reason for that is that the research shows that in the short term, CBT-I and medications are about equally effective, but in the long term is where CBT-I has the advantage. So think of medications as sort of covering up that symptom and just hiding the symptom, but when you take the medications away, the symptoms are going to come back often. So CBT-I is really looking to get to the root of it and cure the insomnia by correcting the things that are driving it and causing it to continue. One problem, though, is that access to CBT-I is pretty limited. So here in the Chicago area, we don't have that many, but we actually have a lot more CBT-I providers than other parts of the country. I think there's more and more people being trained in it, but like I said before, behavioral sleep medicine is a pretty niche field. There's not a lot of people doing it. So oftentimes when you go to a sleep clinic, most sleep clinics don't have a psychologist. At Northwestern, we have two, but that's not the norm. Most sleep clinics won't have a psychologist. And so you may have to go out and find a book or a website to do CBT-I, or if you're lucky, maybe you can find someone at a regional hospital that does it. So that's a problem that hopefully will get better with time, that there'll be more access to it because it really is the best treatment. One point I want to make is that CBT-I is not the same as sleep hygiene. Sleep hygiene might be a term that's familiar to you. It's a term that I think often comes up if you look online for sleep tips. And sleep hygiene can mean different things. So in behavioral sleep medicine, what we mean by sleep hygiene, it's just this small set of recommendations that are good preventative habits. They're a good foundation, but they're not going to cure insomnia. So things like limiting caffeine or alcohol, those are certainly good habits. But when someone's at that chronic insomnia stage, those are probably not the issue. Usually people have taken care of those already. And then they're saying, well, I've already done all of these things. Why am I still not sleeping? Well, sleep hygiene is not enough. So think of it as like dental hygiene. If brushing your teeth and flossing, it's good prevention. It's going to help to prevent a cavity. But if you have a cavity, there's no amount of flossing or brushing that's going to fix that. Then you need something else. So that's where CBT-I comes in. This is really the effective treatment for insomnia, and it incorporates multiple different strategies. Let's review sleep hygiene in case some of these things are maybe new. So like I said, these are just really good foundational things that you should do to help maintain good sleep. They're good habits. So some basic things like, of course, just your bedroom environment, making that comfortable, dark, cool, quiet, all of that. Avoiding caffeine late in the day. Caffeine affects people differently, and so that's something that you would need to monitor for yourself. Generally, most people can handle a cup or two of coffee in the morning. Some people can handle more. Some people, even that just makes their heart race. So it really depends on you, but avoid it too late in the day because it does have a long half-life. Avoiding alcohol within a few hours of bedtime is important because alcohol has that initial sedating effect, but then it really disrupts sleep quality. You wake up more, you have poor quality sleep. So having that close to bedtime really disrupts sleep. Avoiding heavy meals close to bedtime, especially if you have any acid reflux or GERD issues. Exercising regularly is important, but usually not too close to bedtime. For most people, exercise is sort of stimulating and energizing. So if it affects you that way, you just don't want to do it too close to bedtime. And in general, it's good practice to limit naps to no more than about 20 or 30 minutes and to avoid napping late in the day. And the reason for that is your body's building up this sleep appetite throughout the day, what we call your sleep drive. So think about if you have a snack before dinner, you're not going to be hungry for dinner. So with your sleep, it works that same way, that if you have a long nap, it's like having a really big snack. You're going to spoil that appetite. So you want that sleep drive to build up through the day and get really high. That's what's going to help you to sleep at night. Some strategies that I want to recommend, especially for people who maybe have recently developed insomnia, or if you're a person who did sleep well in the past, I think one thing that's really important is to not overreact and make drastic changes, because that can actually start to make things worse. There might be things that were perfectly fine for you in the past and don't need to be changed. And these are some really common ones that I come across. So one would be to completely eliminate caffeine. So again, this is individual, but if you're someone who historically drank 2 cups of coffee in the morning and slept fine, then 2 cups of coffee is probably fine for you. Maybe you could try cutting back and just see if it makes a difference, but it may not make a difference because that's probably not the reason why you developed insomnia. I think if you're having a lot of anxiety, it wouldn't hurt to cut back a little bit. But if you're feeling tired or sleepy, a little bit of caffeine might actually help you get through the day. So you don't need to completely eliminate it. Another thing that people often do these days is because we've all heard of these things about blue light and electronics and screens. And so people will completely avoid all of that at bedtime or before bed or for a few hours before bed. And again, I really would look at, how were you before you had this sleep problem? Did you used to just watch TV? A lot of people come in and tell me, I used to just watch TV and then go to bed and I slept fine. Well, then TV wasn't a problem, right? It wasn't causing insomnia then, so we can't blame it on the TV now. And sometimes when you take those things away, those things that are they're a nice calming, mindless distraction. So for a lot of folks, something like TV or reading on their tablet, maybe that's a really relaxing routine, and you take that away and then there's just more anxiety at bedtime. So that's not helpful. So it is good to minimize the light from those devices, turn the brightness down, increase the distance from your eyes. But for a lot of people, I don't think you need to completely avoid it. One thing that is usually not helpful with insomnia is to use a sleep tracker. So this could be something on your phone, or if you're wearing a smartwatch type of device. If you're someone who's maybe sleeping fine and you just find it interesting, that's great. Or if you're someone who's not giving yourself enough time to sleep, then that could help motivate you to create that time. But in insomnia, the problem is there's plenty of time to sleep, but the person is not able to sleep enough. They're awake too much. And focusing on that sleep tracker and paying a lot of attention to it usually just makes things worse. It makes the anxiety about sleep worse. You look at that data in the morning and it's frustrating that it's not what you want to see. So if it has that kind of effect, I would encourage you just to not look at the tracker, take the watch off at night. Tracking your sleep is not necessary or helpful for insomnia. Okay, let me just check the time. Okay. So we're going to get into a couple of big strategies from CBT-I that are really helpful. And to lay the groundwork for that, I want to just talk a bit about how sleep works. So one really important thing is that you can't make yourself sleep. And actually trying to sleep, focusing on it, makes it harder to sleep. The harder you try, the more alert you'll be. So sleep is really something that happens on its own. So we're not, in CBT-I, we're not teaching strategies that will make you sleep. It's knowing how to regulate your body's natural processes and set the stage for sleep to happen on its own, just like it used to happen when someone was sleeping well. The body knows how to sleep, and so we just need to create the right conditions and address things that are interfering with those. So this is essentially how sleep works, really simplified, is that it unfolds on its own when the conditions are right. And those conditions are, it's the right time of day. So that's the circadian rhythm process, that timing of when your body naturally wants to sleep. And two, you're sleepy enough. So that's that sleep drive or that sleep appetite I was talking about earlier. So that needs to build up for most adults for about 16 hours or so, that you're awake to build up enough sleep drive to sleep through the night. And thirdly, that there's nothing interfering with those. So it could be the right time of day, you're really sleepy, but if you're in pain or there's noise, there's a lot of things like that can get in the way of sleeping. So we want to address those factors if possible. The biggest piece of advice I have for sleep, if you remember nothing else from this, is that consistency, especially with the wake time, is really, really key. So consistent wake time, that's the #1 recommendation, because what that does is it really regulates those natural biological processes, the circadian rhythm and the sleep drive. And the wake time is really important because you have control over that. You can set an alarm, you can get up at the same time every day. And then that allows you to build up an adequate sleep drive, get your body onto a good rhythm. And then when you do that, the consistent bedtime will naturally follow. But if you just focus on the bedtime and just go to bed at the same time every night, you can't force yourself to sleep. And what you may be doing is going to bed when you're not actually ready to sleep and just trying to sleep. And that's going to make it worse. So the advice is to keep a consistent wake time and aim for a consistent bedtime, but don't force it. Just go to bed only if you're sleepy. So maybe if you generally go to bed at, let's say, 11, you might be aiming for that, but if for whatever reason, like you watched the debate last night and you're just really fired up, don't go to bed. You're not going to fall asleep. Give it some time. And along with that, one thing that's really important for everybody is allowing time to wind down. And you may need more or less time to wind down. I think everybody needs at least a half hour. Some people maybe need a couple hours or 3 hours. You need that transition between being active and productive and really engaged. And you need time to let your mind and your body just slow down and become calm again. You're setting that stage for sleep. So doing something that is just relaxing, mindless, calming, whatever that might be for you. Some people like to do meditation or some type of guided relaxation as a way to help get their body and their mind prepared for sleep. So that's one tool that could be helpful. It's not making you sleep, but it's helping your body to become ready to sleep. Your body's going to sleep on its own. What you're doing is allowing your body to become calm enough that that sleepiness will come out, that sleepiness that's there. All right, so sleep consolidation is a strategy that is really, really effective for insomnia. I'm going to walk through what this is. So this is about spending the right amount of time in bed, not spending too much time in bed. When you spend a lot more time in bed than you're actually sleeping, you're just creating room for more wakefulness. So here's an example of someone who's spending 10 hours in bed from 9 to 7, but they're only sleeping 6 of those 10 hours. So this blue is where they're asleep. And you can see there's large periods of wakefulness interspersed throughout that. So this person's probably pretty frustrated. It's taking them a while to go to sleep, and then they're waking up during the night. Their sleep, it's really unconsolidated, it's fragmented, it's not going to be good quality sleep. So what we want to do in sleep consolidation is, first of all, say, okay, you're sleeping 6 hours on average. Let's get that to be a consolidated 6 hours, because even if it's not more sleep total, if it's more consolidated, it's going to feel better. So this is what I mean by consolidation, is compressing that together. And the way to do that is to, counterintuitively, it's to decrease the amount of time you're spending in bed. If this person's only sleeping 6 hours, then we reduce their time in bed to 7 hours, which gives them plenty of time. What's going to happen is they're going to start to sleep more solidly through the night. And the way that this is working, this goes back to that sleep drive process, that sleep appetite. Rather than going to bed at 9, they went to bed at midnight. So they stayed up, they got really, really sleepy, because normally they would have been sleeping here. So they pushed through that, they got really sleepy. So then they go to bed, they not only fall asleep quickly, but then when they wake up during the night, they're going to fall back asleep pretty quickly. So you're building up that sleepiness high enough that it can carry you through the night and you get a consolidated sleep. So our goal in this is to get the sleep consolidated, and then sometimes to see if we can increase that a little bit. But that's basically what it involves. And you can do this from the other end too. You can also wake up earlier if that feels more natural to you. If you're more of a morning person, maybe you'd rather say, okay, I'll just wake up at 5 and keep the same bedtime. So either way, you're reducing the time in bed to make it a closer match to how much you're actually sleeping, okay? Rather than trying to go to bed, spend more time in bed, trying to force yourself to sleep longer. That just doesn't work. And some things that are important is to think about, what do you do when you can't sleep? There's some things that are unhelpful and some things that are helpful. So we'll go through the unhelpful things first. Some unhelpful things that people often do are things like checking the time every time they wake up. And if you have insomnia, that's likely going to make you feel frustrated or anxious, because you're going to look at the clock and think, why am I awake? Now I've only got 3 hours. And all those thoughts are just going to make you feel more upset. So it's good to just not look at the clock or cover it up so you don't see it. You're not tempted to look at it during the night. It's also not helpful to stay in bed for a long time when you're feeling awake, frustrated, or anxious, because over time, those become conditioned associations. The bed starts to become a place that feels frustrating. And when you get into bed, you feel awake because it's become associated with that. So that's just this Pavlovian conditioning, that when two things occur together repeatedly, they become associated. And so in insomnia, a lot of folks will tell me things like, I'll be falling asleep on the couch, and then as soon as I get into bed, I'm wide awake. And it's that conditioned anxiety or wakefulness that your brain thinks that's what the bed is for, because it's experienced that so often. So we'll talk about what to do instead in the next slide. Trying to sleep is not helpful. Turning on a lot of light is not helpful. Engaging in planning or worrying, those are often what people are doing, but those are really active types of thinking that are going to keep you awake. Some people will just get up and do something productive, thinking that they might as well use that time to do something. And you're not giving yourself a chance to get sleepy and calm if you're engaging in something productive. That's going to be stimulating. So think about that, those nighttime hours but you've budgeted that for sleep. So if you're awake during the night, you don't need to do anything productive. That can all wait for the daytime. It's better to do something that's just calming and sort of boring. So let's talk more about that, the things that are helpful. So rather than staying in bed and just trying to sleep, tossing and turning, getting frustrated, it's better to just get out of the bed. And we say within about like 20 minutes or so, just when you get that gut feeling that it's just not happening, you're awake, get out of bed, go somewhere else, and do something that's just sort of calming and relaxing, just to pass the time until you're sleepy. And don't go back to bed until you actually feel drowsy or sleepy. So when you're out of bed doing that, minimize the light, just enough light to see what you're doing or to be safe walking around the house. Certainly if there's any issues with being unstable, just stay in bed. Don't get out of bed if you're concerned about falling. But if you're able to get out of the bed, go somewhere else, like the couch or another room, and just do some relaxing thing, something that for you is the kind of thing you do to wind down before bed, whether that's reading or watching TV or listening to the radio, anything that you would just find kind of boring, calming, and mindless. And another thing that's really important is just to be aware of your mindset and the thoughts that are going through your mind when this is happening. that frustration and that anxiety. It's a really natural reaction to insomnia. It is a frustrating experience, but it's not helpful to just sit in that anxiety or frustration. So see if you can shift those thoughts, just acknowledging what's happening without kind of getting really frustrated about it, reminding yourself that it'll be okay. If you don't sleep well, if you're up for a long time, think about what realistically will happen the next day. Okay, you're not going to lose your job or something terrible is going to happen. You're going to feel tired. It won't be a great day. You might struggle a bit, but you'll get through it, and you've likely done it before. So it's helpful to be able to remind yourself of that in the moment, to sort of reassure yourself. Think of this, the kind of thing you would tell a friend. If it was a friend or your partner telling you they can't sleep, they're frustrated, what would you tell them to help them feel better or reassure them? And if you can think of that, tell that same thing to yourself. It's a really helpful way to think about it. Okay. So that was just a really quick overview of some of these core CBT-I strategies. And I want to close with some specific things that I think have become really important during COVID-19. I think one of the main things that's really affecting sleep is just the loss of structure and a lot of routines and activities, and that has ripple effects in ways for sleep. So just in general, for mental health, it's good to have structure and routine during the day. So if that's something that has been lost, I encourage you to create that in whatever way you can. Maybe that means just having a routine of what you do every morning, every afternoon, building in activities, scheduling things, writing them down, creating some kind of structure for yourself. Because that daytime structuring routine also helps with then having a nighttime structuring routine. So it's sort of a 24-hour process. A couple big things that, of course, people have lost are ways that they used to exercise and socialize. Hopefully by now at this stage, you've found some ways to continue doing those. But if you haven't, I think that those are really important things to make sure you're still getting some kind of physical activity in whatever way you feel is safe for you, and some type of social interaction, whether it's attending these kind of talks or talking to friends, whatever it might be. Maybe you have someone that is also being safe in quarantining that you can meet up with. I think that socialization is really key. Another thing that's changed with people maybe not going out as much is sometimes people aren't necessarily getting light. So let's say you used to leave the house every day to go to work and you're not now, so you can stay inside virtually all day. You may have to build this into your routine to actually make sure you get bright light. That's important for regulating that circadian rhythm. So you can do this by just going outside for half hour, or sit by a window that gets bright light. In whatever way you can, get some bright light, in like morning or midday is a really good time to get that, to help strengthen that circadian rhythm. And then one thing that is also important is to think about news and all of the stressful things that are on TV and in the newspaper, and just know yourself of, is that something that is really negatively affecting you? How do you balance being informed, but not to the point that it's causing you to stay up unable to sleep or really affecting your mood or mental health? It's okay just to cut back or just stop all of that for a week and just see how you feel. I think that's a really important way to take care of yourself, especially during this time, is to limit that if that's something that you feel is affecting you. And I'm going to end with some resources, and Michelle, if you'd like, you can send out lists of these resources later so folks have them. Here's some resources for CBT-I if you would like to look into doing this on your own. There's some digital resources. The website Path to Better Sleep was developed by the VA, but anyone can use it. It's free. You don't have to be a veteran. It's a really good online CBT-I. Cleveland Clinic has a website and an app called Go to Sleep, which I think costs about $40. There's this Insomnia Coach app, which was made by the VA. It's not like the whole CBT-I, but it does give you some basic information. And there's some tools for doing that sleep consolidation process. So that's an app you could download for free. And then there's some really good books that will guide you through CBT-I. These first three are more like workbooks where you go through and learn all the strategies. Good Night Mind is a book that's smaller and just has these short chapters on these different strategies. And so it's a really nice book if you're not necessarily wanting to dive into a big workbook yet. And all of those are pretty cheap and easy to find. You can get them from the library too. And then if you're looking just for general information about sleep or about any other sleep issues, these are some really good websites from the National Sleep Foundation, the American Academy of Sleep Medicine. The Pediatric Sleep Council has a really good website with all sorts of information about infants, children, and adolescent sleep. And behavioralsleep.org is the website for our Society of Behavioral Sleep Medicine. So all of those have information for patients if you're looking for information. Okay, so that wraps up that portion. I'm happy now to transition to taking questions if we have any, Michelle.
Yep, there's a few of them. The first question is melatonin effective for people having sleep problems? And if so, how do you determine what is a safe and effective dose?
Okay. Well, I'll preface it just with saying I'm not a medical provider, but melatonin is something that I frequently encounter. So melatonin, what it's best for is shifting the circadian rhythm. So in our clinic, what our physicians usually are recommending it for is for people who are extreme night owls or extreme morning people, what we would call either advanced sleep-wake phase disorder or delayed sleep-wake phase disorder. If that sleep timing that your body naturally has is really out of sync with your job and responsibilities, then melatonin, and this is something you would want to go to a physician for, because the timing and the dose really matter, and that has to be personalized. So it's a small dose, like a 0.5 milligram or 1 milligram at most, a small dose taken at a specific time. So for example, if you're a night owl and you're trying to get onto an earlier schedule, you don't take it at bedtime. You'd probably take it a few hours before bed. But again, it depends on you, and you'd want to get an assessment. So it really helps with those issues, with shifting the timing of your sleep. And this could also be relevant if you're someone who does shift work or is experiencing jet lag. And actually for jet lag, there's nice online tools. One of them is called Jet Lag Rooster, just a website where you can plug in, of course now we're not traveling internationally, but in the future, if you're doing that, you can put in your itinerary and get recommendations for when and how much of melatonin to take and when to get light, when to avoid light, and that helps with jet lag. So that's what melatonin is best for. There's evidence that it has a little bit of an effect as a hypnotic, helping people to fall asleep, but that's not really its primary purpose. What I would generally say is if you're taking it and you feel like it helps you sleep, then keep taking it, that's fine. But if you're taking it, let's say you're taking a 3 milligram, that's a pretty common dose you could buy. If you're taking 3 milligram and you don't feel like it's helping, I wouldn't take more than that. If you take too much, it can actually stay in your body too long and maybe throw things off the next day. So I wouldn't encourage you to take like 10, 20 milligrams. That's not likely to help.
Okay. Next question goes back to when you were talking about CBD. Why haven't they done?
Hi, excuse me. Can I ask you something? I'm on the phone.
Sure.
Okay, my name is Susan, and I have sleep apnea, but I was diagnosed like maybe 7, 8 years ago, or maybe more, and it was severe. But I went like this year in November, and they said I have like positional sleep apnea, and I've never heard of that.
Yeah, positional sleep apnea, that just means that it's worse in a certain sleeping position. When you do a sleep test, they're able to measure the position you're in, whether on your back, your stomach, your left, your right side, or sitting up. And so they're able to look at in what position where the apnea is happening. And it's really common that apneas will happen more when you're on your back. And so that's usually what positional apnea means, is that you would have to double check what your results were, but that's usually what it is that it was probably worse on your back.
But which side is the best side, the left or right, or does it matter? Because I'm a back sleeper. I'm not on this, I try to do it on my side, but then I roll over on my back.
Well, ask the physician, because depending on your results, you might have different amounts of apnea on your left or right side. So you'd want to ask your physician. But there are devices that are made to help people stay on their side, because you might roll over on your back, even if you start on your side. So if you look, what are they called? There's one called like the slumber bump is one of them. If you just look up like sleep apnea back pillow, it's like, it's sort of like a thing you strap on, or you can make your own. You can put a fanny pack on and like put tennis balls in it, put that around your back. So the tennis balls will help to keep you from rolling onto your back. So you can make a device like that, or you can buy them. Those help you to stay on your side.
Where do you buy it?
I've seen them online. I don't know if there's any stores that sell them.
I'm not too good online.
Yeah, I don't know if there's any. Ask your physician. Yeah, they would be able to help you with that.
Okay. Okay, thank you so much. I really appreciate it. And I'm
Okay, we're going to move on. So back to when you were talking about CBD, the question is, why haven't they done any of these long-term studies? Is there a lack of funding for this type of research?
I think a big issue here is, and this is case with almost any of these supplements or herbs, is that these are not things that you have a patent on, right? This is not like there's an incentive to do big studies and long-term studies when if CBD was something that I had a patent on, so if it's effective, I can make lots and lots of money. But right now, everyone's just selling it. And so there's not really, for the companies that are selling it, there's not an incentive for them to do studies. Especially if there's a risk the studies may show that it doesn't actually help. So there's no incentive for them to do it because people are just happily buying it anyhow. I think though that I'm not sure what the funding is. I know that there are people researching this in academic settings where they're not concerned about making money. They just want to know the science. So I think that the fact that it's a supplement that's not patentable, I think that's a big reason why we don't have enough research.
Great. Next question is, can you discuss benzodiazepines for sleep and its dangers? And is there any correlation between the benzos and dementia?
Okay, well, I don't know if I have the full answer to that. I'll tell you what I know, but our physicians would know more than me. So benzodiazepines, so this is things like Xanax, Klonopin, those are common ones, Ativan. They're commonly prescribed for anxiety and sleep. They're not, most of them are not recommended. They're not on the guideline of recommended medications for insomnia. So generally, in our clinic, what we see is a lot of people come to us and they've been prescribed it elsewhere, but then the physicians in our clinic are going to switch them to something else that's more preferred. So there's a couple concerns with benzodiazepines. One is the tolerance that develops, that usually people develop some dependence and tolerance. And so it stops working as well. It kind of is hard to get off. You have to go down really slowly. So that's not good. There's also concerns with increased risk of falls. I don't know about risk of dementia with those, so I can't answer that, but I think the increased risk of falls and the dependence are two reasons why they're really not preferred for sleep.
Great. This is kind of a comment and a question. Back in the 70s, there was DOD work on non-pharmaceutical anesthesia that induced shaped electrical neural patterns. Think of it as a sleep helmet. Was that research a dead end? Are you aware?
I am not aware of that. That sounds really interesting. No, I don't know anything about that, actually.
Two more questions right now. If Benadryl helps to stay asleep when prescription medicines do not, but it does not seem to make you sleepy if you don't go to bed, is there any problem using it often?
I'm again going to tell you what I know our physicians usually tell patients. Benadryl would not be something they would recommend taking chronically, regularly. It's probably one of the most common things people take because it's easily available over the counter. That's what's in a lot of those over the counter sleep aids. It's usually diphenhydramine or Benadryl, or doxylamine, I think is the other antihistamine. It's not recommended though long-term for insomnia. If you're taking that chronically every night, what you will probably experience when you try to stop taking it is that there's this rebound insomnia where your insomnia gets worse than it was to begin with. That'll go away, but that will happen temporarily. And then you just want to get back on it. So that makes it difficult. what I've heard, I think, is that the long-term chronic use of those is associated with an increased risk of cognitive problems. So I think that's a big reason to not take it long-term.
Okay. A few more questions that have popped up. How about, and I know you're not the physician, but how about where'd it go? Magnesium glycinate for sleep.
I do not know, actually. I know a lot of people are taking that. I don't know if there's any evidence for that. I can't answer that, unfortunately.
Okay. How do poor sleep habits affect lifespan?
Well, I guess I would say not poor sleep habits so much, but certainly the amount and quality of sleep is important. I mean, what we're finding out more and more, it's funny that for a long time, sleep just has really not been on the radar for most people. We've paid so much attention to diet and exercise, and we all know that those are important for everything, right? Diet and exercise are important for any health condition you can think of. Having poor diet or not being active increases your risk of cancer, cardiovascular disease, diabetes, everything. And sleep is, what we're finding is essentially the same thing. Sleep is basically the third pillar of health. It's exercise, diet, and sleep. So if you're chronically not getting adequate sleep, or you've got, let's say, untreated sleep apnea, that's going to increase your risk for a variety of different health outcomes. So it doesn't mean like one poor night of sleep or one period of insomnia is going to make you more likely to get sick or die. But yeah, there is increased risk of morbidity, mortality with chronically poor sleep.
Okay. And there was another, just a quick question. I think it's about your familiarity. I'm not sure about it. It is about another medication, Silenor or Silenor, Silenor.
Is there a question about it, or? I mean, what I know about Silenor, so that's the brand name. The generic name is doxepin. It's an antidepressant that it's used in higher doses as an antidepressant. It's used in lower doses for sleep. It is on the list of recommended medications for insomnia. It's one of the medications that is recommended. So it does have evidence showing it helps. Yeah, so it's something that our physicians prescribe quite a bit.
Okay. That is actually the end of the question specific for you. There was just a question. If our attendees here are able to access this, and yes, it is recorded, and I will be sending out an email in the next few days once we are all done buffering with a link so that you can get the recording, along with the list of all of the resources that Dr. Mundt did allow and provide for you tonight. Thank you very much, Dr. Mundt, for the presentation this evening.